All right. So thank you everybody um, for joining us today. I am very excited to have Dr. Chalmers speaking to us on bronchiectasis and PCD. We also have Michelle Mannion, who's the executive president of the PCD Foundation and co-founder with Lynn Ernie, who is also here, who's the executive assistant and clinical centers coordinator for the PCD Foundation. I am Mary. Oh, I am also Lynn Ernie, according to the slide. That's what happens when you're rushing and copying and pasting. I am, in fact, not Lynn Ernie. I am Mary Kitlowski, and I am the president of Running on Air. And I'm very excited to be hosting this with the PCD Foundation as part of the World Bronchiectasis Day. For those of you who may not be aware, last year, Dr. Chalmers was one of the co-founders or co-starters of World Bronchiectasis Day. And with the coordinated with the COPD Foundation and a lot of other patient organizations across the globe to help raise awareness of bronchiectasis. I want to tell you a little bit about Running on Air and about me. So I am a PCD patient. I started Running on Air back in 2014 when I went on supplemental oxygen. I have one sibling, and my sister also has PCD. So we had some challenges going on supplemental oxygen, and thus Running on Air kind of came into fruition. And our focus this year in particular has been on supplemental oxygen. One of the things I'm excited about is the supplemental oxygen comparison chart that we put out, came out at the American Thoracic Society conference this year. And you can message me if you have any questions or any interest in that. I know we're not all on supplemental oxygen. And just wanted to mention our social media sites. You can follow us and get up to date on new webinars. We hope to be doing more of these in the future. And now I'd like to introduce Michelle Mannion, who, as I said, is the executive president of the PCD Foundation, co-founded the foundation, was it like 21 years ago now? And she is the parent of an adult PCD patient.
Thank you. Thank you, Mary. And just wanted to mention that this webinar, we're really delighted to be involved with it. It is almost entirely Mary's efforts and Dr. Chalmers' good graces to speak. So very, very big thanks to you guys. I had some technical difficulties this morning, so the slides that I prepared are actually on a different computer. So I'll just tell you a little bit about PCD Foundation. We started in 2002 with the goal of really creating a community for PCD, specifically with getting more attention for research so we could better understand this disease and get some effective treatments. We now feel we're to the point where it's not just treatments. We really would like to see there be cures for PCD. Lynn Ernie was right there with me the whole way. So we've been involved in this now for 21 years. And I have, of course, none of my social media things or our website, but maybe we can put that in the Q&A, Lynn, or so I apologize for that. But finally got onto the webinar. So at least that part worked. But once again, thanks, Mary and Dr. Chalmers, and we're looking forward to this.
Yeah, thank you. All right, well, I have the privilege of introducing Dr. Chalmers. He's professor of the Asthma and Lung UK Chair, Asthma and Lung UK Chair of the Respiratory Research at the University of Dundee, and a consultant for respiratory physician at Ninewells Hospital in Dundee, UK. His main clinical interests are in difficult lung infections and particularly bronchiectasis. He runs a research group focused on developing new treatments for bronchiectasis and related conditions. He chairs the European Bronchiectasis Registry and is the current chair of the European Respiratory Society Bronchiectasis Clinical Practice Guideline Panel. He is current chief editor of the European Respiratory Journal. And I will just say, I am convinced that he does not sleep. So with that, Dr. Chalmers.
It's a lovely introduction. We don't have time to sleep because we need to cure PCD, as we've just heard. So we all share the same objective, and my great thanks to the PCD Foundation and to Running on Air and all of the patient advocacy organisations that have worked with us on this World Bronchiectasis Day to raise awareness of these conditions.
Dr. Chalmers, all of a sudden your audio sounded far away. Is everybody else experiencing that?
I think I'm just trying to share my screen. Would you be able to enable me to share my screen?
You should be able to now, is it not? Because
it says host disabled participant screen sharing.
All right.
Sorry about that.
No, that's all right.
And that's probably me pressing buttons is probably responsible for the audio problems.
Okay, try that now.
You've got it. Thank you.
Okay, sorry about that.
No problem. Here we go. And so let me know if you can see the slides okay.
Yep.
Right. So the topic I was asked to talk about is bronchiectasis in PCD. Now, the first thing to say up front is that not everybody who has PCD has bronchiectasis, and not everybody that has bronchiectasis has PCD. And so I've not assumed that everybody knows everything about bronchiectasis or what I'm going to talk about. So some of the introduction to what bronchiectasis is will be old news for some of you who've lived with this condition for a long time, but I think it's good to go through each of the components of the disease. So I'm going to talk a bit about what bronchiectasis is. I'm going to talk about PCD and why I think that we need to raise awareness of the condition and address the underdiagnosis of PCD, and then also talk about how we treat bronchiectasis and how we might be able to treat it in the future. So just the question and answer is very important. So Mary, if we're going on too long, just tell me and we will make sure that we get plenty of time for the Q&A.
Yes, and thank you for mentioning that. I didn't say that at the beginning. If you have any questions, please put them in the Q&A area. And just a reminder that Dr. Chalmers cannot answer any specific health questions related to for you, but is giving this overview as general. Thank you.
And I always put this disclaimer up front, which is that I'm going to talk about research studies and various bits of data. They may not apply to you, and you should always discuss anything with your doctor if you have any questions about anything that comes up during the webinar. So let's talk about what bronchiectasis is. So not everybody who has PCD also has bronchiectasis, but many will develop bronchiectasis through their lives. And bronchiectasis is from the Greek bronchi, meaning the airway tubes, and ectasis or ectasia, meaning widening. So it's widening of the airway tubes. Normally, when you breathe in, air goes through these nice narrow tubes that are designed to conduct air into the edges of the lung where oxygen is taken up into the blood. And when damage occurs in the airways, you get this widening and scarring of the airways. And you can see an example of that on the right-hand side of the slide. Almost looks like little grapes or a little branches on a tree that have been damaged. And that's really what it is that the furthest away parts of the lung become damaged and are not able then to fulfill their main function, which is to take up oxygen and to protect our bodies from infection. Because our body's actually an amazing magical function Your lungs are constantly in contact with the air, and you breathe in about 100,000 bacteria in every cubic meter of air that you breathe in. So you're constantly in contact with the environment. And if you're outside, you're also breathing in particles from the air. But your body has mechanisms to deal with that. And of course, one of the most important are these little hairs called cilia that flick the debris or the bacteria out of the lungs after they've been trapped in mucus. And everybody needs this to keep their airways clear, because you inhale nearly a million bacterial cells per day. So if you didn't have this function, you're at higher risk of picking up infections. And that's where we come to primary ciliary dyskinesia. So if you're not able to clear the airway tubes can become full of mucus. And this, on the right-hand side at the bottom, you can see an example of a damaged, slightly disordered airway with the green stuff inside, which is the mucus. We talk about this in terms of a kind of vicious cycle where you get inflammation in the lungs. That damages the airway tubes. The tubes then can't clear the mucus. The mucus gets stuck. Bacteria like to grow in the mucus, and that causes more inflammation as the body tries to clear away the infection. And round we go, leading to the condition that we call bronchiectasis. In people who've got PCD, we think that this cycle obviously starts with the failure of the mucus clearance, but PCD is not the only cause of bronchiectasis. And so sometimes it starts with other types of damage, such as a severe infection. And I see that a lot in my adult patients. They get a nasty infection and that causes some damage and a similar kind of presentation. So I'm going to show you some data from European patients with bronchiectasis. And I'll show you later also some data from American, US patients with bronchiectasis, because they're very similar. We now have really big registries for people with bronchiectasis that can tell us a lot about the symptoms and the natural history of these conditions. And that's helping us to understand a bit more about what bronchiectasis is and how it affects our patients. So firstly, what are the most common symptoms? So this is now looking at a survey from nearly 1,000 patients. The most common symptom on the top left is coughing up sputum. The second most common is having chest infections, so what we call exacerbations. Another very common symptom is tiredness and not feeling fit for activities. And around 3/4 of patients also experience shortness of breath. Cough is also a common problem, as are sleeping problems and anxiety. Very few patients, if you look at the bottom, say that they don't have sputum or tiredness as an issue. So most people who have bronchiectasis experience chest infections, sputum production, tiredness, and cough, at least to some extent. Some of the less common symptoms like losing weight or coughing up blood, they do happen, but they're less common, thankfully. So I often say to my patients that bronchiectasis is like a box of chocolates. You don't know what you're going to get. As Forrest Gump used to say, every patient that I meet in my clinic is a little bit different. Some patients produce large amounts of sputum and really struggle with that. Some patients have a dry cough and feel very tired. Some people have lots of chest infections, and sometimes I meet patients who have bronchiectasis who've never had a chest infection in their life. And so everybody is a little bit different, and that makes our job finding the right treatment quite difficult, because actually the treatment has to be personalized and individualized to the patient. But the most common ones are a cough, often coughing up phlegm. The breathlessness is because those tubes that have been damaged are not so good at taking oxygen up into the bloodstream. And so particularly when the airways are full of mucus, they're not very good at taking up oxygen, and so you feel out of breath. The body uses a lot of energy to fight infections, and so fatigue is a very common symptom. And a lot of my patients will complain of chest pain, chest discomfort, and that's often the phlegm gets stuck in the tubes, and the airway tubes aren't able to clear the mucus, and so they feel a sensation of either pulling, tightness, or fullness in the chest, and that's actually a sign that the airways need to be cleared. And I've mentioned already frequent chest infections are a common a common feature, because that's again a sign that bacteria or other bugs have built up in the chest. How common is primary ciliary dyskinesia across all of the patients that we see with bronchiectasis? Well, here's some research. This is the data that we collected in Europe on 17,000 patients from 28 countries. And you can see from the pie chart that idiopathic is a fancy medical term for I don't know why you've got this disease. We make up clever medical terms to hide our ignorance in medicine. And that is the most common situation in people with bronchiectasis. And post-infectious is the second most common. PCD is this little group here, and it's 3%, or just over 500 people in this particular study. Okay, you're going to see when I show you the next few slides that that is a gross underestimate of how common PCD really is. If we look at the United States also has a register for people with bronchiectasis, and this is all causes of bronchiectasis. And in one of their most recent reports, they reported 79 patients out of 2,170, which is also about 3%. So it's almost exactly the same as the study I showed you from Europe. So at the moment, if you were to read these reports, you would say PCD is about 1 in 30 of all the people with bronchiectasis in Europe or the US. Okay, but I'm going to show you some research now from my amazing colleague, Amelia Schumark, who does a lot of research into PCD, which is that we don't find what we don't look for. And when she's looked in the UK at how often people with bronchiectasis are tested for PCD, she looked at about 5,000 people, and only 95 out of 5,000 have had any tests done for PCD. So most people who are walking around with a diagnosis of bronchiectasis have not ever been tested for PCD. And even in people who had very severe bronchiectasis, only around 2.5% had had any kind of testing, and only about 6 people had had full testing. So that's why we don't see so many PCD patients in these adult studies, because nobody's testing for it. You don't find what you don't look for. And so one of the jobs that we have is to raise awareness amongst physicians to think about PCD as a possible diagnosis. Because we've looked in other studies, and again, this is work from my colleague Amelia, where they've taken people with bronchiectasis and done genetic testing. This is a UK-wide study called the 100,000 Genomes Project. They took people with bad bronchiectasis, so low lung function, or who had family members who had bronchiectasis, so they suspected there might be a genetic cause to the disease, and people were referred for genetic testing for PCD. And the bottom line was 12%, or more than 1 in 10, had PCD in this study. So lots of people who had bronchiectasis of unknown cause actually had PCD. And we've done a similar study across Europe where we screened 500 people who were deemed to have a low likelihood of PCD, and these were all adults, and another 3% had PCD. So what I'm telling you is that at least half, and probably a lot more than half, of all PCD cases have not yet been diagnosed. And lack of testing and underdiagnosis is a really huge problem. And people like me have a big job to do to tell our colleagues who look after bronchiectasis patients that they need to think about and diagnose PCD. Why is that so important? Well, we have research that shows that the earlier you're diagnosed with PCD, the better you do. So this is data from the London PCD service, where they've looked at the age at which PCD was diagnosed, which is on the x-axis of this graph, and lung function, and the likelihood of being infected with Pseudomonas, which is a bug that I'll talk about a bit later. And the bottom line is the earlier you're diagnosed, the better your lung function, and the less likely you are to have infection with bugs that we don't like. So earlier diagnosis prevents people from turning up in clinics with more severe disease because they've not received the right treatment. So it's really important that we think about bronchiectasis and make the diagnosis earlier. So how do we make the diagnosis? Bronchiectasis itself is diagnosed by CT scan. PCD, you'll have heard, or many of you will be PCD patients, so you've had tests yourself to diagnose PCD. That's not done by the CT, but the bronchiectasis is diagnosed by the CAT scan that gives a very detailed view of the lungs and allows to see the widening of the airway tubes that is the diagnostic feature of bronchiectasis. Okay, what else do we look for when you come to clinic? I sometimes describe myself as a sputumologist because I'm obsessed with sputum. And your doctor, if you're a PCD patient, will ask you more or less every time you come to clinic to bring a sputum sample. So why are we so keen on sputum? Well, I'll tell you my favorite fact, which is where does the green color of phlegm come from? Lots of people think it comes from bacteria, it comes from Pseudomonas or something like that, but that's not actually true. It's your immune system contains one green protein. It's called myeloperoxidase. That's not very important, but what it means is that the color of your sputum is a measure of how much inflammation there is in the lungs. And so when we ask you about sputum samples in clinic, or we talk about sputum color, we're really looking for how much inflammation is there in the lungs as a sign of how at risk of chest infections or bad symptoms you might be. So there you go, good fact. That's what causes the color of the sputum. And we like sputum that's white because that means it's not got lots of inflammation in it.
Dr. Chalmers, sorry,
Yes,
if I can just interrupt you for a second. I've seen a few people raise hands. We're not taking questions, audibly. If you have questions, please type them into the Q&A chat. And we will be asking those after the presentation. Thank you. Sorry.
Thank you. No problem at all. And I promise I will try and answer every question that you have once we get to the end of the presentation. And I just had a quick peek at the questions, and there's a question there: is the mucus different in PCD patients? You'll be very pleased to know I'm going to talk about mucus now, so I'm going to answer that question right away. Because I was just talking about inflammation. The inflammation in the lungs that people with PCD get doesn't just affect the cilia, it actually damages the lining of the lung as well and stops the immune system from clearing infections properly. And so you'll sometimes hear people say that they feel like they've got a weak immune system because they pick up every bug that's going around. And you're actually right, it's the inflammation damages the immune system that lines the lung as well. And so even in people with PCD, this inflammation is very important. And you'll hear about this thing called elastase, which is a particular type of inflammation that's very important in PCD. And the other thing that happens in PCD and in all causes of bronchiectasis is not just that because the cilia don't work as well, the mucus isn't cleared so well from the lungs, but also you make more mucus. So your body recognizes there's a problem, and one of your body's responses to recognizing that there's a problem with infection is it makes these glands. I'm pointing with the pointer at these glands. These are mucus glands, and your airways have a few of these mucus glands to make mucus. But in PCD in particular, but also in all kinds of bronchiectasis, your body makes more and bigger of these mucus glands in order to try and, it thinks it's protecting the lungs by making more mucus, but actually, of course, it's causing us a problem and it's causing us symptoms. And so part of the problem in PCD is not just failure to clear the mucus, but also making more mucus than the body needs. And so the question that was in the Q&A is the mucus different in PCD? Yes, it is. So I'm showing you here again some cutting edge research. On the left-hand side is a measure of how much mucus there is in the lungs from healthy people. And remember, healthy people have a bit of mucus to keep the airways clear, but there's loads more in people with bronchiectasis. If we compare healthy people, people with COPD, people with bronchiectasis of other causes, and this is the total amount of mucus in the lungs, the two groups of people with the largest amount of mucus in the lungs are cystic fibrosis and PCD. So PCD isn't just a condition where the the cilia don't clear the mucus well. Over time, inflammation also means that there's more mucus in the chest. And the mucus contains lots of mucins, which is the thing that your body thinks it's using to defend you against infection. So that's an important thing to know. So the slides just froze for a moment there. I'm hoping it's going to come back. If not, I can just keep talking about mucus all day because I'm a mucus obsessive. Yeah, sorry, the slides have just frozen for a moment, Mary.
That's all right. Yeah, let's give you a minute to try to get those back up.
Yeah, I'm hoping it will. Yeah. So there's a question. I'll address one of the questions. So there's there we go. There's a question in the chat. What's the best way to find out if my son has, who's got PCD, has bronchiectasis? If he's known to have PCD and he's under the care of a physician, a respiratory physician, they'll be following up that the child often with lung function tests. The diagnostic test for bronchiectasis is a CAT scan, but you don't want to have CAT scans on too regular a basis because they're a radiation test. So the likelihood is that they would only do a CAT scan if there was a suspicion of bronchiectasis because the lung function was getting worse or the symptoms were changing. So squeezed in an answer to a question while we thought of that problem out.
Dr. Chalmers, since you broke for a second for a question and related to it, so you mentioned not every PCD patient has bronchiectasis. Do most adult PCD patients have bronchiectasis?
Yes, so the chance of having bronchiectasis increases as you get older. So not, as you know, more than 50 genes cause PCD. So not all PCD patients are the same. And so your risk of getting bronchiectasis and the age at which you get bronchiectasis depends both on the type of genetic defect you have in PCD and also the care that you receive. So the better you're able to do airway clearance and exercise and avoid infections, the longer we'll be able to delay the development of bronchiectasis. So not every adult who's got PCD has bronchiectasis. I've met and diagnosed people with PCD who don't have radiological bronchiectasis as yet, even as adults. But most, by the time they reach adulthood, most do.
Thank you.
Can I ask a follow-up just because we're kind of on this topic now? I know there's a lot of confusion in the PCD patient population. They think they have two separate diseases. And I know we talk about non-CF bronchiectasis, but is there a way you can or would describe bronchiectasis as a consequence of PCD and not a separate, it's not a separate etiology. It's not something happening separate or outside of PCD.
Absolutely. So I would say PCD and bronchiectasis are the same thing. They're not separate diseases in the same way that cystic fibrosis and bronchiectasis are not two separate things. Cystic fibrosis causes bronchiectasis. PCD causes bronchiectasis. So it's a consequence of PCD. So I encourage my PCD patients to say they have PCD and that as part of their PCD, they have other features, which might include bronchiectasis, rhinitis, hearing problems, or other problems. It gets a bit confusing to talk about them as two different conditions. So the other important bit about PCD is infections, and we will ask you to send lots of sputum samples if you're a PCD patient because we want to find infections. And then the two most common infections in all people with bronchiectasis and also in people with PCD, which you may have heard of, are Pseudomonas aeruginosa and Haemophilus influenzae. And both are bugs that don't normally live in the lungs. They're invaders that shouldn't be there, and they get in there because the airways aren't able to clear effectively. And Pseudomonas is one that we don't like in particular because it's quite resistant to antibiotics and can be quite tricky to treat. Your risk of getting Pseudomonas is quite high if you're a bronchiectasis patient. Around 1/3 of all bronchiectasis patients will eventually be infected with Pseudomonas. And funny, we've noticed that people who live in warmer Southern European countries and certain countries, such as countries in Asia, seem to be more likely to get Pseudomonas. And we don't fully know why that is, but that is the case. PCD patients are a bit more likely to get infections than other types of bronchiectasis. This is again a bit of research where you can see from a study of 350 PCD patients. PCD patients were about twice as likely to get Pseudomonas and also a little bit more likely to get Haemophilus infection. And that's again because the airway clearance, the ability to clear mucus from the airways just isn't quite as good in people with PCD. So I've talked a few times about chest infections, and the medical term for chest infections is exacerbations, where we talk about a flare-up of the symptoms. And the most common situation here is that you get a viral infection, maybe a runny nose or a sore throat, and the virus disturbs the lungs and the bacteria that are living in the lungs and causes an increase in cough and production of sputum, and needs to be treated with antibiotics. And everybody's a bit different. Some people have a lot of those chest infections and some people don't. Chest infections like that can be a problem because they affect the lung function. And so we try to prevent those if we can. There are medications we can use to prevent them, and airway clearance can prevent, which I will talk later on. Something that we observed during the COVID pandemic, which I'm going to talk about now, is that viruses probably do cause a lot of these flare-ups. And if you look at the green on this graph here, this is from our bronchiectasis patients. The green is people not having chest infections. And you can see in the 2 years before the pandemic, only about a third of people didn't have a chest infection over the course of a year. And about 80% didn't have a chest infection during the year of the COVID pandemic because we were all wearing masks and keeping our distance from each other. And so this is a reminder to those of you who've got bronchiectasis that viruses probably cause a lot of these chest infections. So if the grandkids have snotty noses and a virus, tell them to stay away until they've got better, because that probably drives quite a lot of these chest infections. What do we do in clinic? So I run a big bronchiectasis clinic in the east of Scotland where we look after a lot of people with bronchiectasis, including a lot of people with PCD. We'll ask questions about symptoms and how often people are having chest infections, because our main goal of treatment is to improve quality of life, reduce symptoms, and stop those chest infections. And the regular tests are breathing tests. So the spirometry, where you breathe into the tube, helps us to monitor how things are progressing. Questionnaires about symptoms, sputum samples, so we can look for those bugs like Pseudomonas. And we might also do blood tests to look for complications of bronchiectasis. Those are the sort of routine things that we do. And most people are seen in the UK every 3 months or every 6 months. It's different in different countries, but that's what we do. I've already told you that I'm a sputumologist. So I'm going to tell you now what I do with the sputum once you give us a sample. So sputum is really important because it can tell us lots about, including the color, which tells us about the inflammation in the lungs. It can tell us lots about what's going on. This is me just being very childish now. This is me drawing somebody's name in Pseudomonas in our lab. You can have fun while you're having science as well. What we do is we take a sputum sample and we take it to a microbiology lab and we put it on a plate like the one that I wrote somebody's name on there. And we can grow the bugs that are living in the sputum in order to find what would be the best antibiotic to treat you with if you've got an infection, and also to determine whether you have any of these infections that need special treatments like Pseudomonas. An important message to give is that a positive sputum test doesn't always mean that you've got an infection that needs an antibiotic, because sometimes the bugs are just living there at a low level and they're not causing you a huge problem. So a positive sputum test doesn't always mean that you need an antibiotic, but it does help us to know if there's infection there and what to treat with if you do develop symptoms like an increased cough or more sputum production. So we call that colonization, when the bugs are just there, but they're not causing too much mischief. This is an overview of all of the different treatments that we can give for the management of bronchiectasis. And there's lots on this slide, so don't try and take everything on this slide. I'm just going to direct you to the top 5 sort of headlines here, which are treating the cause if we can. And at the moment, there isn't a specific treatment for PCD, but watch this space. We hope that there is specific treatments coming very soon. Improving airway clearance, which is the most important thing that we can do, get that mucus out. Controlling infection, which is often with antibiotics. Improving lung function, which may be with inhalers. And controlling complications if they arise. So those are the big things that we do. And the boxes that we tick every time a patient comes to our clinic. So I'm going to spend a little bit of time talking about a few of those. And the most important, particularly for PCD patients, is airway clearance. If you've got cilia, as illustrated in the bottom right, that aren't clearing the mucus from the lungs, the only way the mucus is going to come out is if we cough and we force it out using air and our respiratory muscles. And so there are a whole variety of different techniques that we can use to clear mucus from the lungs. And the best way to learn is to be taught by a respiratory physiotherapist. If you've not seen a respiratory physiotherapist, and we know from surveys that many people don't have access to that, particularly in countries with less well-developed healthcare systems than ours, there are videos you can watch online on YouTube on how to do things like the active cycle of breathing technique. But in my view, people with PCD should be referred to specialist centres where they can see physiotherapists and learn how to clear their chest properly. There are also devices that can use air to force mucus away from the airway wall and help us to clear them out of the tubes. And that's an example of one of those devices. There are many such devices that can be used, again, best done under the direction of a physiotherapist. This has to be done every day. And I say to my patients twice a day as a minimum if you have PCD to clear your chest. And a good analogy here is cleaning your teeth. So if you think about the bugs in your lungs, like the bugs that grow in films on your teeth, you might not feel unwell if you don't clean your teeth for a couple of days, but certainly over a long period of time, your teeth would become damaged and you'd have to go and see the dentist. The same is the case with the bugs that live in the lung. Okay, if you don't clear them out on a daily basis, at least twice a day, they build up, they cause damage, and we don't have I'm the equivalent of the dentist for the lungs, and we then need to use antibiotics and other treatments to try and fix the problem. So the toothbrush analogy, I think, is a good one for the clearing of mucus from the lungs that has to be done religiously every day. How good is this thing called airway clearance? Well, if this was a drug, if this was a pill, and we could sell this, it would make us all millionaires because it's an incredibly effective treatment. In people who have bronchiectasis, who do airway clearance, this is data from a randomized controlled trial where half of the group did airway clearance and half of the group didn't do airway clearance. And it cut the number of chest infections by half, from 2 to 1. And it caused a big improvement in quality of life, bigger than we've seen with any drug. So the message is this is a really effective treatment that everybody should do. It takes time. It can be tiring for patients. And I know many don't enjoy doing airway clearance, but it is really effective for the management of bronchiectasis. We can help you from a medical point of view with the clearance of mucus. I've told you that people with PCD make more mucus. That mucus also is very thick because it's full of these mucins that I talked about earlier. And so something that we also add in to help with the clearance of mucus from the chest is often inhaled medications like isotonic or hypertonic saline. Saline is salt water. So you inhale this salt water, it makes the mucus more runny, it's easier to cough up and easier to clear. Carbamazepine and N-acetylcysteine are tablets that do a similar job. They make the mucus more runny. I've talked about devices. And the other miracle treatment that I recommend for everybody who's got bronchiectasis is actually physical exercise. It causes you to deep breathe, it causes you to breathe hard, and that mobilizes mucus, forces it into the center of the chest and causes you to cough at the end of exercise. And so if you can keep fit, go for a long walk or a gentle jog, it's a very effective way to clear the chest. So all of these are part of our toolbox in helping our patients to clear the chest.
Dr. Chalmers, sorry, we're 15 minutes, a quarter before 3. We have about 13 questions. I'm not sure how close you are to being finished.
I'm very close.
Okay.
So,
all right.
I will mention 2 final treatments, which are the antibiotic treatments, which are, one is an anti-inflammatory medication called macrolide antibiotics. They cut the risk of chest infections by about half in people with bronchiectasis. They're taken usually 3 times a week. And it's one of the only things that we have trials for in PCD. So this is a trial that was done in PCD, including children up to the age of 7 and in adults. And it cut the risk of chest infections in people with PCD by about 55%. So if we have bad PCD with bronchiectasis and experiencing lots of chest infections, often more than 3 in a year, this is a treatment that can be recommended. It's not for everybody because it does have side effects, but it is an effective treatment for people with PCD who are suffering chest infections. And the other option when there's infection, particularly with Pseudomonas, is to inhale antibiotics through a nebulizer. That delivers high concentrations of antibiotics to the airways, but it can cause a little bit of irritation. So again, it's not for everybody. I go back to my Forrest Gump, it's like a box of chocolates. You'd never know what you're going to get, and every patient is different and needs a personalized approach to management. I've talked a lot about bronchiectasis, and I always make the point that PCD is not only about the lungs, and so it's also important to remind my colleagues who do respiratory medicine that it's not all about the lungs, and also that we also manage the nose, the heart, and provide counseling, address fertility issues. Your physician should offer you vaccination, and also psychological support is very important when you're living with a chronic disease. So all of these things are important parts of managing PCD. For the last 2 minutes, I just want to give you some exciting hope, I guess, which is there's never been more research into bronchiectasis. This was an orphan disease for a long time, and this is from the Public Library of Medicine, all of the articles that are being published on bronchiectasis, and you can see it skyrocketing every single year. And there's more pharmaceutical companies and charities now investing large amounts of money into finding treatments for bronchiectasis and specifically for PCD. And we've partnered with a number of these in the European space. There are new treatments for inflammation coming, and one particular type of inflammation caused by those neutrophils is being targeted by a new treatment called DPP-1 inhibitors, which have been shown to reduce exacerbations. And there's a phase 3 study of that medication, which results should be available next year. And really excitingly, the potential to correct the basic defect in people with PCD, which is there are now clinical trials of mRNA therapy, which is correcting the genetic problem in people with PCD, looking to fix the problem and maybe lead us on the road towards a cure. So the final message, I think, is research is ultimately going to give us the answer to both bronchiectasis and PCD, and it's these developments are not too far away. So hopefully when somebody gives this talk in a couple of years' time, they'll be able to tell you about lots more exciting treatments that are available for PCD. So my summary is bronchiectasis affects many people with PCD. PCD is underdiagnosed in people with bronchiectasis, so we have a job to do to raise awareness. I'm passionate about advocating for airway clearance, but there are other treatments that can also help people with PCD, and have hope because treatment is improving all the time and research is making a really big difference. Thanks to wonderful people like Michelle, Mary, and the charities that advocate for this disease. So thank you, and I look forward to taking your questions.
Thank you very much, Dr. Chalmers. And I also just want to say to everybody, last week in New York was the World Bronchiectasis Conference, the second time it's been in the US. It was the sixth one that's been held, and it will be in Dr. Chalmers' backyard next year in Dundee, Scotland. And it was also wonderful hearing PCD mentioned so much at the conference, and the emphasis on the importance of diagnosing bronchiectasis patients that may have PCD.
Yeah, and I should mention, I mentioned it during my talk, but my very close colleague Amelia Schumark is really the PCD expert, has done a lot of that advocating within the bronchiectasis community to really raise the awareness of the condition and push for more diagnosis, and is doing a wonderful job through this project called Beat PCD.
And having an international impact. She is all over the place. She's helping us with some stuff at Mayo Clinic, and she's helping us in Puerto Rico. So she's been amazing.
Yeah. If you open the dictionary under autumn, you'll see a picture of her. So you should have invited her to give this talk rather than me.
All right.
So one thing that I noticed in the questions, Dr. Chalmers and Mary, is that a lot of them are kind of process questions about how you get the care you need. And I think it would be helpful just to mention that across Europe and across North America, there has been a monumental effort to get specialist centers set up that can really be helpful to make sure that you're getting your sputum checked when you need to, you're getting the CT scan to diagnose bronchiectasis. So to me, that would be a first. Try to find a center as close as possible to be getting care.
Absolutely. And if you have PCD, you really should be being looked after by a specialist who knows about the management of bronchiectasis and about the management of PCD. So do try and get in touch with your nearest specialist center if you're able to do so. We're regularly now receiving referrals from all over our country, looking at people looking for care for their PCD, and we're very keen to ensure everybody with PCD sees a specialist.
I'm going to start the questions off. There was one that I received, an email. So what is the current recommendation to treat recurrent Pseudomonas infection in PCD patients with bronchiectasis? Is it still inhaled Toby 4 weeks on, 4 weeks off? And for how long?
It's a great question. So there isn't one treatment for Pseudomonas. There are multiple treatments. So for my PCD patients, I recommend one of two things for Pseudomonas. I mean, the first is we try and eradicate it if you grow it for the first time, which is with a 3-month course of antibiotics. If it's stuck there and it won't go away and it's causing symptoms and chest infections, inhaled antibiotics are one option. In the US, Toby is very widely used. In Europe, colistin is very widely used. They're both inhaled antibiotics. There's no evidence one is better than the other, but those are good treatments. The other one that works well is the macrolide tablets. So the tablets that I mentioned that are 3 times a week also seem to prevent chest infections in people with Pseudomonas. And that's important because not everybody can take the nebulizers. Some people get coughing and wheezing with the nebulizers, but either of those options seem to work quite well.
Question on GI issues. Are GI issues related in PCD or bronchiectasis, or from the amount of coughing that patients do?
Yeah, so a lot of our patients with bronchiectasis complain of tummy issues, diarrhea, constipation, irritable bowel type symptoms. Sometimes the question is it to do with sort of swallowing sputum? I wonder if a lot of it's to do with the antibiotics that people have to take because of chest infections and that upsetting the bugs that live in the gut. And there's some recent research that shows that people with bronchiectasis have a very different microbiome. Those are the bugs that live in the gut to people who don't have bronchiectasis. And that's probably because of repeated antibiotic exposure over time. So we need to do some research to find out whether probiotics, those sorts of things that you can drink to restore the microbiome, would help those sorts of symptoms. but certainly that it's a very common if you've got bronchiectasis to have tummy problems.
Lynn, was there something you wanted to add or say, or? Okay, never mind.
Mary, there's a question here related to Recode Therapeutics, I think would be good to discuss. Specifically, is it likely that Recode therapies will be available for all PCD patients?
So, I mean, those are questions that are probably best addressed to the company, but my understanding is at the moment, because there's so many different genes that cause PCD, this is a treatment that needs to be tailored towards specific gene defects. And so it's something that will become available for subgroups of patients initially, and it'll take time for it to be something that's available for everybody. But I don't have any relationship with Recode Therapeutics, so they're the best qualified people to answer those questions.
So we have been working with them a little bit just to get information, and it's exactly what you say. And some of the things for patients with PCD to understand is that some of the genes in PCD are huge. So when you're attempting to do a gene-based therapy, that creates a challenge. So Recode is initially going for genes that will be amenable to the therapy they're proposing, DNA I1 and the CCDC39 and CCDC40. And then if we see that those are successful, then we'll be moving on to some of the more challenging genes. But yes, the goal is to have something for everybody.
Okay. What initiates the inflammation pathway in PCD? Is it debris or microorganisms?
Oh, great question. So it's probably actually the mucus getting stuck in the airway tubes. So particularly at the beginning, if people are not suspected of having PCD, they're not doing airway clearance, the airway tubes become stuck with mucus, and the body tries to clear that, and it causes an inflammatory response. And once that gets started, it's difficult to stop, and it causes the production of more mucus and sets up this pathway. So it's a reminder that actually clearing the chest and doing that airway clearance every day is also anti-inflammatory, because you get rid of the inflammatory debris, and the body makes less inflammation if you're able to get rid of the mucus. So that's probably what initiates it right from the beginning.
Dr. Chalmers, there's a question about the azithromycin therapy. Is it taken forever for prevention or possible infection? Could you describe the two different ways azithromycin is used?
Yeah, so obviously azithromycin is something that is used as an antibiotic all over the place. The Z-Pak is very common as a treatment for respiratory infections outside of PCD. Where it's used in people with PCD or in bronchiectasis is it's given usually 3 times a week at a low dose to have an anti-inflammatory effect as well as a slight antibiotic effect. And it inhibits those cells that I called neutrophils earlier. So it reduces the amount of sputum that's being produced and stops chest infections from happening. You don't always have to take it forever. So with my patients, I often give it for a year. And at the end of a year, I have a chat with my patients about whether they feel that it's benefited them and whether they would like to continue with it or not. Some people decide to try off it because they don't like the idea of being on antibiotics forever. Some people say, this has transformed my life, I love this medicine and I want to stay on it. And so it's very much something that we decide on an individual patient basis, but it doesn't always have to be forever.
We have a question. How often do you suggest to do a check on the mucus?
Very good. So I say to my patients every single time that they see a doctor, because it's easy to remember then, just take a sputum sample with you. Yeah. So if you've got a chest infection, it's great, and you're going to see the doctor to get a course of antibiotics, take a sputum test. If you're going for your routine 6-monthly checkup, take a sputum test. And that way we'll get what we need, which is a test a couple of times a year at least, and ideally ones where you get when you've got a chest infection so that we can guide antibiotic treatment. So that's an easy one to remember. Every time you're going to see Dr. Chalmers or anybody else, take them a little present and they'll thank you.
Dr. Chalmers, we've talked a lot about mucus and sputum. Could you explain the difference?
So it's basic. I use the two words interchangeably. So sputum is the word for what we cough up, and sputum contains mucus, which is the proteins that your body uses to trap things in the airways. So we can talk about mucus, we can talk about sputum. The Scottish word is phlegm, which is another one. Yeah, or glut is the other one that Scottish patients use, but they all mean exactly the same thing.
All right. Is there any evidence that early PCD diagnosis and starting earlier in the airway clearance therapy decreased bronchiectasis? And you did speak to this.
Yeah, so there's several studies that show this. So there's studies from the Brompton that I showed an example of, where your lung function was much better if you were diagnosed as a child than if you were diagnosed as an adult. There's some work from the group in Bern in Switzerland that shows that the earlier you're diagnosed, the more you preserve your lung function. So that means less bronchiectasis. So I think earlier diagnosis definitely makes a difference. And we know that in other diseases as well. So the earlier you can pick this disease up, the better. It's always a sad situation for me as an adult physician to diagnose somebody with bronchiectasis at the age of 40 or 50, sorry, with PCD at the age of 40 or 50, which I do, and they've had symptoms since they were 2 or 3 years old. And you just think we've missed so many opportunities to make this diagnosis. It shouldn't happen. It shouldn't happen. And in the future, we need to make sure it doesn't happen.
Dr. Chalmers, I just want to do a time check. It is 3:01, and this was a 1-hour webinar. So I, want to be mindful of your time. We do have more questions, and if you're able to answer a few more, that would be great. And if not, okay.
Oh yeah.
There's I think an important question, and probably more for North American patients, and you might be surprised by this, Dr. Chalmers, but there is an incredible use of steroids and corticosteroids in PCD in North America, including inhaled and also oral. Not so much at PCD centers, but people that are not seen at a specialized center. Lots and lots. In a recent abstract, 85% of PCD patients indicated they had been.
Wow. Okay.
Yeah, and I know that is not currently commonly done in Europe, but this question relates to having had that kind of treatment. This is a 32-year-old patient, but she's got spinal fractures. She's got issues related to steroid treatment that make it difficult to do exercise and airway clearance.
Yeah, so a small proportion of people with PCD also have asthma. Okay, so the airways in PCD fail to clear things very well. So that means they can also fail to clear allergens. And so people with PCD often develop allergic type symptoms, or more commonly than the general population. And so there's a small group of PCD patients who have an asthma type syndrome where steroids are perfectly reasonable. But I'm talking about 5 or 10%, not 85%. So for most people with PCD, there isn't an indication for steroids. And as you've pointed out, Michelle, they have a lot of side effects like diabetes, fractures. And so they're best avoided. I don't use them unless my patient also has asthma in addition to PCD.
Dr. Chalmers, I'm going to ask this question, and I'm going to give my answer to it first. Should we start using the term PCD bronchiectasis when speaking of bronchiectasis and PCD, like the term CF bronchiectasis? And just for people who are not familiar, it's CF bronchiectasis, and then non-CF bronchiectasis is the rest of us. So my answer is absolutely, we should be saying PCD bronchiectasis. Dr. Chalmers.
Yes, so I said earlier in response to Michelle's question, if my PCD patients ask me how they should describe themselves, I think you should say PCD, and bronchiectasis is part of the PCD. So that would be my answer. In the same way that if you asked a cystic fibrosis patient what condition they had, they would say they've got cystic fibrosis. So as not to confuse it with non-CF bronchiectasis. PCD needs specialized treatment, and so it's important it's recognized as an individual entity in its own right.
Do you have any thoughts on phage therapy to control Pseudomonas aeruginosa infection?
Yeah, so it's not being widely used at the moment. So it's an experimental treatment. It's been used in some cases as a sort of last resort desperation therapy for people with highly resistant bugs. So it's not something that you should go out and ask for tomorrow. But there are trials going on of phage therapy as a potential treatment for difficult to treat Pseudomonas. So it might be something that comes in the future as another weapon for us to try and get rid of Pseudomonas. My own view is it isn't going to be the treatment for everybody because it's quite complex to put together cocktails of phages and to administer them. But it may help for some people. I'm going to take the prerogative to steal one of the questions that's just in front of me, because one of the questions that's just come up is how effective are mucolytics for PCD? Because it allows me to express my undying love for hypertonic saline, which is a treatment I use for most of my patients that have PCD. So if you think about the tubes being blocked with mucus and there being no effective cilia to clear the mucus out, the only other thing we can do apart from coughing is make the mucus thinner and easier to clear. And so for a lot of my patients with PCD, I recommend using mucoactive medicines like inhaling salt water, because that makes it easier to clear the mucus from the chest. Again, like all the treatments, it's not for everybody, but it's one that I really, really use a lot and get good feedback from patients on.
All right, there's a few questions on using the azithromycin. So one, does a 3-time-a-week azithromycin cause hearing loss?
Only extremely rarely. So the reports of hearing loss are mostly from studies where people use 250 milligrams every day, which is a very high dose. And of course, the higher the dose you use, the more side effects you get. The dose I tend to recommend is 250 milligrams 3 times a week on a Monday, Wednesday, Friday. It's very rare to get hearing problems with that dose. But if you do get hearing problems, if you notice ringing in the ears, just stop the medication, because it'll go away if you stop the medication when you first notice the tinnitus, which is the ringing in the ears.
And then with azithromycin, is it recommended for people who have a colonized bug that is resistant to the drug?
So great question. So azithromycin probably works mostly as an anti-inflammatory rather than as an antibiotic. So when we did our research, the people who responded best in terms of feeling better and having less chest infections were people who had Pseudomonas infection. And azithromycin doesn't kill Pseudomonas as an antibiotic. So it was obviously working as an anti-inflammatory, stopping the mucus rather than directly working on the Pseudomonas. So you don't need to worry about resistance with azithromycin. It can work for people even if you've got a bug there that doesn't usually respond to azithromycin. A lot of doctors don't know that, and so they avoid the drug in people who've got Pseudomonas, and that's probably the wrong thing to do, because we've shown that it works really well in those patients.
This question, what therapy is available for pseudocolonization when you can't tolerate any nebulized therapy?
Okay, so the 3 times a week azithromycin that I've mentioned works for Pseudomonas. It doesn't clear the infection, but it reduces the symptoms and stops the chest infections. The other treatment, firstly, there are several types of inhaled antibiotics. So if you haven't tolerated one, it's worth trying a different type, because some people who can't take Toby can take, for example, Caistin or Colistin. So that there are alternatives there. In some cases, though, we have to use regular intravenous antibiotic therapy to control Pseudomonas. And in some of my most difficult patients, we use a midline, which is an IV line, and patients administer antibiotics into the vein at home every 8 weeks or so to keep the Pseudomonas under control. That's uncommon, but it's something that we do in really difficult cases.
Is the Pseudomonas infection in PCD different from Pseudomonas in cystic fibrosis with relation to biofilm and chronicity?
Almost certainly not. So it's the same Pseudomonas. It comes from the environment. It infects the lungs in the same way. People with PCD are a little bit less likely to get Pseudomonas than CF, although that now may change because of the big changes that there's been in how CF is managed and how the available treatments. But the bug itself is fundamentally the same and has a similar impact on the lungs.
The one difference we see sometimes in the PED population is that you can eradicate it at least for a while in kids with PCD. And usually when a kid with CF gets it, they have it forever.
Yeah, and that's also what we see in non-CF bronchiectasis, is that we're a little bit more successful at getting rid of it, but we're not sure why that is. Maybe the lung damage is just not quite so extensive.
Is it common to experience an exacerbation but have no change in inflammatory markers in bloods? Any reason why this might be the case?
Yes, very common. So the blood and well, I'll put this in a different way. Your lungs are amazing. Your lungs are absolutely amazing. Just think of the lungs of somebody with PCD can have 10 million cells per milliliter of Pseudomonas. And those bugs only stay in the lungs. They don't go anywhere else in the body, because your body's got this amazing system to wall off the infection and keep it in the lungs. So you think about that. If you've lived with Pseudomonas all of your life, it only stays in the lungs. It doesn't go anywhere else in the body, because your body's brilliant at compartmentalizing it, keeping it in the lungs. And so that's why you often don't see a change in the blood inflammatory markers or symptoms like a fever with a chest infection. You can do, but you often don't, because your body's very, very effective at keeping it all contained within the lungs. And that's what your immune response is trying to do, because it wants to keep everything in the one place so that you don't get a nasty, overwhelming infection. Yeah, very, very common to not see anything in the blood.
There are a couple questions related to gene and disease progression. Is a specific gene associated with worse disease progression in PCD bronchiectasis?
Yeah, so there are genotype phenotype correlations. So there are some genes that are associated with worse outcomes and some genes that are associated with better outcomes. That's not my special area of interest, so I'm not able to answer each individual gene, their relative pathogenicity. But yes, there are some that are associated with slightly more risk and slightly less risk. There's also some genes that make you more likely to have the heart on the other side, and some that are less likely to be associated with that feature.
A question about the chart that you shared showing the mucus production.
Yeah.
So the person said they were confused. It looked like, so your chart with mucus production that broke down the individual disease groups, would you say that PCDers have more mucus than CFers? They were confused because PCD looked just above CF.
Yeah, so it's about the same. On that graph, it was about the same. So that graph wasn't volume of mucus, it was the concentration of mucin, which is the mucus in the chest. So that usually means more mucus, but it also means that the mucus itself is thicker and contains more mucin, meaning that it's therefore more difficult to cough up. So it suggests that the mucus in PCD is thicker and a bit more difficult to clear, and there's more of it than in conventional non-CF bronchiectasis, which is another reason why airway clearance and some of these medications that I've talked about, like the mucoactive medicines, should be used a bit more often in people with PCD than in the non-CF bronchiectasis that we've talked about.
There's a question here related for the role of surgical lobectomy, and it kind of gets to the difference, I think, between focal bronchiectasis and diffuse, that I think would be helpful for patients to understand.
Yes, so in most cases of PCD, because the gene is missing everywhere, the bronchiectasis is diffuse. It affects the whole lung. It tends in PCD to start in the lower part of the lung because that's where gravity makes the mucus pool, but it then affects the middle part and eventually the upper part of the lungs in some cases. So we call that diffuse bronchiectasis because it's spread in lots of parts of the lungs. In some cases of bronchiectasis, particularly after a nasty infection, you can get just one part of the lung that's affected. And that can be, if you have a surgical operation on that one area of lung, that can cure the symptoms. That's very rarely the case in PCD. There are some cases I've seen of PCD patients having surgery, but usually it's to remove one very damaged area of lung rather than to be curative. So in the vast majority of cases, surgery isn't part of the treatment for PCD.
So this can be a common question that gets asked. Can one use vigorous exercise, and they give the example of an hour and a half playing tennis, to replace airway clearance sessions?
This is where suddenly my physiotherapist comes and drags me off stage because she and I are having this conversation on a regular basis. So the view amongst most physiotherapists is that we should do exercise and airway clearance. So they both should be considered together. One shouldn't replace the other. But many of my patients tell me that they clear their chest wonderfully by doing aerobic exercise and that they don't necessarily feel that they need to do more. And I always tell the story of my gentleman in his 60s who's got the worst bronchiectasis probably in my entire clinic, and he wouldn't mind me saying that, who runs about 5 kilometers every day, and I don't think I've seen him for a chest infection for about 10 years because he clears his chest so brilliantly from doing his regular running. So clearly regular physical exercise is a great way to clear the chest and to control the disease. But to avoid being assassinated by my physiotherapist, I will say you should also do your airway clearance as well.
Yeah, especially, there's some folks that physically can't run 5 kilometers, and that's perfectly fine.
Yeah, and that's perfectly fine. Yeah, but I would say even gentle exercise along with your airway clearance can make a really big difference. So I talk to my patients about just going for a short walk every evening with your wife or your husband, or going for a little jog around the block if you can. It doesn't have to be intense, award-winning exercise. It's just something that gets you breathing hard, will recruit those collapsed airways and clear some mucus. It's a very effective way of keeping yourself healthy. And tennis, I saw in the question, tennis is great. Tennis is really excellent.
Probably all that moving, stopping and going and moving helps shake the sputum a bit too.
Exactly. Lots of upper body movement and lots of deep breathing is fantastic for clearing mucus. So yeah, whatever works for you. There isn't one perfect form of airway clearance. That is something me and my physiotherapist always say is the best type of physio is what works for you and what you're happy to do.
All right, I just want to do a time check with you again. It's 3:18, and we do have some more questions.
Yeah, I'm admiring of our participants who've all stuck with us for longer than the webinar. So I'll keep going as long as our participants are happy to keep going.
All right. What are the treatment implications of asthma and overly in PCD and bronchiectasis? So I guess if there's an asthma component.
Yeah, so we sort of touched on that earlier with Michelle, didn't we? So there does seem to be quite a lot of people with PCD who have asthma type symptoms. And I guess that's because the lungs are not so good at clearing allergens, and often asthma is an allergic problem. And so in that situation, there is a benefit from using inhaled corticosteroids, which are the steroid inhalers. And when you get flare-ups, particularly if there's a wheezy noise that the doctor hears when they listen to the chest, corticosteroids, so prednisolone often is an appropriate treatment. But the warning I will give is that there's a lot of misdiagnosis of asthma in people with PCD. So if you go to a doctor in my country, and I'm sure it's the same in a lot of other countries with a cough, the first label you get is asthma. And then it takes a number of years before you get diagnosed with PCD, but the asthma stays on your chart. And so people give you the steroids because somebody wrote asthma on your chart 10 years earlier. So make sure that if you have got a label of asthma, just make sure it's an asthma diagnosis that's been made properly by a chest physician, and that it's not a misdiagnosis with your PCD, because that happens a lot.
I think we estimated at one point that 95% of PCD patients had been told at some point they have asthma, and probably 10 to 15% actually do.
Yeah, and that's exactly my experience as well. And it's true for everybody with bronchiectasis. So if you cough at least in my country, in the UK, you get a label of asthma at some point.
Would it be recommended for people who have an asthma diagnosis and then before they receive their their PCD diagnosis to ask to be reevaluated?
Yeah, so my patients ask me often, because this comes up all the time. If you've got a label of asthma or COPD, which are the two common airway diseases that get misdiagnosed, ask your doctor the next time you come to see them, do I really have those, or was that a misdiagnosis? And we'll be, if your doctor's anything like me, we'll be happy to explain to you, or if the tests haven't been done, to do the tests to check. Because if you don't need to take the medications for those diseases, we should avoid them. As Michelle mentioned earlier, steroids do have side effects.
Right.
So I cure a lot of asthma by just stopping medications and fixing misdiagnosis.
There's a question here about another co-occurring diagnosis. We hear a lot about this here, and that is the co-occurrence of PCD with an immune deficiency, or misunderstanding PCD as an immune deficiency when they're treated a little bit differently. And this question is about a 2-year-old with PCD and bronchiectasis, and discussion about weakened immune system. Is there anything else that can be done to boost the immune system?
Yeah, so obviously I can't make any recommendations, particularly for a 2-year-old as an adult physician. But it's very common for people who've got PCD or bronchiectasis to be labeled as having a weak immune system. And what it really means is that they're very susceptible to chest infections. But it's not that the immune system doesn't work, it's that the cilia don't work, and so the immune system's not able to fight off the bugs. So the best way to treat it, I'm sorry to always go back to the same thing, is to clear the mucus from the chest. And the immune system will actually reset and be more functional once you unblock the airway tubes. And some of the medications that we've talked about can also help to prevent infection.
Along those lines, someone asked if there's a link between PCD and autoimmune conditions like celiac disease.
Not that we know of. There are some autoimmune conditions that cause non-CF bronchiectasis. And there is a link between bronchiectasis, including cystic fibrosis, and conditions like rheumatoid arthritis, where we think that the chronic inflammation in the lungs actually confuses the immune system and causes it to then cause damage to other things like the joints. So it's possible, but not a common association. So in most cases, if you have those two separate conditions, you've been unlucky and you've developed two separate conditions.
At the risk of sounding like a broken record, again, if you go to a PCD specialist center, they're used to seeing patients that have this confusing mix of different things, and they can help you sort that out.
Question, let me see. Is it bad to be on continuous inhaled antibiotics alternating each month?
So no, it's not bad. So if that's been prescribed, that's very likely because of a Pseudomonas infection or another nasty infection. And the evidence is that reduces the risk of chest infections, improves lung function, improves quality of life. So it's not bad. It's a good treatment and it's been proven in trials to be a good treatment if there's a chronic infection in the lungs and frequent chest infections.
If you have positive MAC infections, how do you treat with prophylactic zithromax or azithromycin is the typical IV treatment for a MAC infection?
There you go. So that's a very important point, not necessarily for patients, but for doctors. We talk about this a lot. So MAC, for anyone who doesn't know, is Mycobacterium avium. So it's a very rare bacteria that infects the lungs of people with bronchiectasis. It's rare, but it can happen. And when you have that infection, you need to take multiple antibiotics for quite a long time. And so we avoid giving azithromycin by itself to people with that infection because it needs to be given in combination with other antibiotics. So in MAC infection, you give azithromycin, but you also give it in combination with at least 2 and often 3 other antibiotics to treat the infection.
Yeah, and so I just want to add to that. So MAC is a NTM, a non-tuberculosis mycobacterium, and the first World NTM Day is August 4th, and Running on Air has been posting periodically some NTM facts. So if you're interested in learning more about NTM, you can go to our social media pages to learn a little bit more about NTM.
So I just have to ask this to a person who lives in Scotland. Does living in a dry or humid area hurt or help with bronchiectasis?
Oh, I'd love the opportunity to live in a dry and humid area. I don't know is the answer. So our evidence suggests that in hotter countries, there's a slightly higher frequency of things like Pseudomonas, but that might not be to do with temperature. It might be to do with other things. But it's certainly dehydration is a problem. If you're in a hot environment, whether that's on holiday or because you live in a hot climate, if you become dehydrated, your mucus also becomes dehydrated and it becomes thicker. And so regardless of where you live or what you're doing, always make sure if you've got PCD that you're well hydrated, because your mucus clearance will be much better if you've got more hydrated sputum. So that would be my main takeaway, is particularly if you live in a hot and humid climate, make sure that you're always well hydrated.
The one thing that we've kind of noticed here is the best way to have good outcomes isn't the climate, it's can you get the care you need, because getting the right care for PCD and bronchiectasis can be really challenging. So having that someone you trust to do your care seems to be more important than the climate.
I completely agree. I mean, that's the big battle at the moment, is getting our PCD patients recognized and diagnosed, and then finding a physician to look after them who's knowledgeable about the condition. And if we could do that, that's half the battle won. But there's still a challenge.
Is there an age limit for mRNA therapy for older patients?
So that one I don't know. That would be one you would need to discuss with the companies that are doing the trials.
Yeah, and it's still being looked into. So
yeah, there's no exclusion or inclusion criteria available yet for any of these trials.
Okay.
There is a question about GERD and lung disease. Can GERD cause lung disease?
So short answer is yes. So severe gastroesophageal reflux. Obviously, your body is designed with 2 tubes very close together. Anything that comes from the gastrointestinal tract can get into the lungs, and it can be quite inflammatory. And so we think in some rare cases, bad GERD, bad reflux, is a cause of bronchiectasis. And it can certainly make bronchiectasis worse in some people. Coughing causes a lot of pressure in the tummy, forces pressure on the stomach, and can cause reflux. And so a lot of our patients suffer with reflux, and it can make bronchiectasis symptoms worse. There's some simple things you can do if you suffer from reflux, as well as taking anti-reflux medication. Sleep with the head of the bed slightly elevated, and avoid alcohol or caffeine related drinks before bedtime, because that relaxes the sphincter that controls the stomach, and so both caffeine and alcohol can make it more likely that you get reflux. Try and eat your dinner earlier in the evening before bed is also another good way of ensuring the tummy is empty, so there's less that can reflux at night time. So it's things that you can do if reflux is a problem. It can contribute to coughing and chest symptoms.
There's a couple of asthma related questions. The first one is, if Symbicort is helping their wheezing, does it mean they have asthma?
Not necessarily. There are some situations where, so Symbicort contains two drugs. One is a steroid and one is what's called a bronchodilator, which opens up the airway tubes. And so in that situation, you wouldn't necessarily know which one is giving you the symptom benefit. And so the best thing would be to ask the question to the doctor, is it, do I have asthma, and is it the steroid that's helping me, or is it the bronchodilator medicine that's helping me? Because the bronchodilator medicines often help people who don't have asthma. Around half of people with any type of bronchiectasis have obstruction to the airway tubes and can benefit from those inhaler medicines. But you're often better off in that situation not taking one that contains a steroid, so that you get less side effects. So discuss that one with the doctor and make sure that if you have a diagnosis of asthma, that the diagnosis is correct.
And the other question, someone's taking Dupixent injections for inflammation and asthma-related symptoms. They're wondering if there's any research regarding that medicine or similar medicine with bronchiectasis treatment and symptom management.
What a great question. So I would like to see that research done. I don't know that it's being done at the moment. So for anyone who doesn't know, Dupixent is an anti-inflammatory injection that amongst other things, blocks mucus production and reduces lung inflammation. It's been shown to be effective in asthma, and it's recently been shown to be effective at stopping chest infections in COPD. I have a strong suspicion it would also be effective in bronchiectasis because of the effects on mucus. And so if anyone who's involved with that is listening, I think we should do some research into bronchiectasis on that one. But I don't know if anyone is doing that at the moment.
Dr. Chalmers, just out of curiosity, with the COPD study then, do they know how many of the COPD patients had bronchiectasis?
They don't, and those
Okay.
studies typically exclude people who have known bronchiectasis. But
Okay.
as you know, they will have included lots of people who had unknown bronchiectasis.
Yeah. Yeah. All right. Well, we are a little past 3:30. And we do still have questions. The questions keep getting added on. So I'm going to ask one last one. Michelle, if there is one last one you would like to ask, and then we'll look at having Dr. Chalmers back at some point, and maybe a way of getting the unanswered questions answered.
Yeah, so I'd be delighted to answer them by email, and we can post the answers online, for example, if that's
Okay.
Yeah, I'm very happy to answer everybody's questions if you want to send them to me.
Okay, great. So the question I'm going to ask has to do with cough. My daughter is not yet diagnosed with PCD, still testing. So how many times per day does somebody with PCD or bronchiectasis cough? As my child coughs 15 times productive cough per day for years.
Okay, so this is unfortunately a how long is a piece of string question. So some patients with PCD will cough only a few times a day, and some will cough almost constantly through the day. It depends on the severity of the lung disease. It also depends on a number of other factors. So there's no right answer to that question, apart from that children shouldn't have a chronic productive cough under any circumstances. So that needs to be investigated, because there are, in addition to PCD, conditions that can cause chronic productive cough in children. So that should be investigated.
I think this is an interesting question too. It's related to oxygen saturation levels. And is it common in bronchiectasis or PCD to have low O2 levels but not require supplemental oxygen? And is that something to be concerned about?
So low oxygen saturations can be due to one of two things in PCD. So it can be due to the lung condition, and I talked about the fact that the damaged airway tubes don't take up oxygen so well. There's also a proportion of people with PCD who have congenital heart conditions because of the way the body develops when the cilia are absent. And so sometimes blood that doesn't contain oxygen goes into the wrong side of the body, meaning the oxygen saturations are always low. So in that situation, the oxygen levels may be low at those sorts of levels your entire life. And I have some patients like that because that's the way that their heart and their lungs are built. But if that's something that should definitely be discussed with your doctor, because the reason for those low oxygen saturations should be known and investigated, and to know whether it's caused by the lung problem, the heart problem, or a combination of both. So again, two possible reasons, but should be discussed with your doctor.
And Dr. Chalmers, one of the concerns there too is damage to other organs because they're not getting enough oxygen. So you may feel fine. There's a lot of patients who do have low oxygen levels and don't seem to have the symptoms. You know, they're not short of breath. That's what we normally think of, right, as being short of breath.
Yeah, so the body adjusts amazingly well to low oxygen levels. So people who live at altitude can live with low oxygen saturations for much of their lives because the oxygen is much lower at very high altitudes. The body adapts, but over time, those adaptations, the changes in the body can be harmful, as you said. So we always like to investigate if somebody does have low oxygen saturations to make sure that there isn't a lung problem or a heart problem that needs treatment.
Well, thank you very much, Dr. Chalmers. Very grateful for your
excellent
time and your expertise.
No, it's been an absolute pleasure. And as I said, you can tell from what I've said this evening in the talk, I'm passionate about raising awareness for PCD and also making sure that as many patients as possible can get good care. And I really must commend Michelle, Mary, and all of the team for the advocacy work that they're doing around this disease, and all of you for enthusiastically participating in the webinar, because it's the World Bronchiectasis Day is about the team coming together to try and raise awareness of this disease and help us push towards those cures that Lynn talked about earlier, and that's where we want to go. So thank you everybody for taking part tonight and being part of this community.
Thank you.
Thank you, Dr. Chalmers.
And we'll see you in Puerto Rico in January. You're still on the list, so.
Fabulous. Thank you.
All right.
All right. Thank you, everyone.
Thank you.
Have a good day.
You too.